Hello, everybody, and thank you for joining us today. It's World Suicide Prevention Day 2024, and this is the day that the Lancet Public Health have launched our series of articles on public health approaches to preventing suicide. Now, this webinar is hosted by the International Association for Suicide Prevention and the Lancet, and the webinar is being recorded, so a link will be sent out to all those who are registered later on this week. Now, we're really pleased that the Lancet Public Health commissioned this series. My name's Alexandra Pittman. I'm one of the 13 authors who contributed to 5 articles in all, and I'm chairing today's webinar. And my job is to start by introducing our first speaker, who is Professor Jane Pirkis, and she's Director of the Centre for Mental Health at the University of Melbourne. And she co-led this series together with Keith Hawton, who will be speaking after her. And after that, he will hand on to Professor Rakhi Dandona, who's going to give the third of our series of talks this morning. So I'm going to start by asking Jane to speak. She will speak for 20 minutes, as will Keith and as will Rakhi, and then we will have half an hour for questions. So please do post your questions in the chat, and then we will be able to read them out and invite speakers to address their answers. Thank you very much, Jane.
Thank you so much, Alexandra. So I'd just like to begin by acknowledging the traditional owners of the lands on which I am, where I'm speaking from, the Wurundjeri people of the Kulin Nation. And I'd also like to acknowledge people with lived experience of suicide, those who may have been suicidal themselves at some point, supported someone who was suicidal, or lost someone to suicide. And in addition to that, I'd really like to thank the folk at Lancet Public Health, and in particular, Audrey Seskia and Hannah Taylor-Lewis and the editorial team, who've been fantastic in getting this series off the ground. So I'm going to provide an introduction to the series and a little bit of an overview. And then Keith's going to provide some more detail about some of the papers in the series, and Rakhi's going to talk about a public health approach from a low and middle income point of view, which we've woven throughout the series. So Alexandra, you're actually undercounting the number of papers in the series. I think you said there were 5, but there are 6. So we have the first paper presents as a conceptual introduction to a public health approach to suicide prevention and presents a model that I'm going to talk about. Paper 2 talks about restricting access to means used for suicide, a very effective public health approach. Paper 3 is about the effect of economic downturn, financial hardship, unemployment, and related things on suicide, and the kinds of government responses that might be helpful or not so helpful in addressing those. Paper 4 talks about the transmissibility of suicide. It takes a particular view on that. Paper 5 talks about particular key risk factors for suicide at a societal level. And then paper 6 is a call to action, where we call on governments around the world to take a public health approach to suicide in order to reduce suicides. So I haven't given any detail about what's in those papers, really, but Keith will talk in quite a bit more detail about the middle 4 papers when he speaks. So this is the team, this is our authors. So Keith and I, as Alexandra said, led the series, and our other authors are Alexandra herself, Dee Knight, Jason Banches, Joe Robinson, Madeline Gould, Mark Signor, Michiko Ueda, Mort Silverman, Murad Khan, the fabulous Rakhi, who'll speak at the end, and Thomas Niederkrotenthaler. It was an absolute pleasure to work with everybody. It was so great putting the series together, which has been an endeavour that has taken over a year, I think. Keith and I have had many meetings at different hours of our respective days. This is where the authors are from. So you can see that we've got fairly good coverage of the world, obviously not full coverage of the world. So to get into the detail of the thrust of the series, suicide, as you would know, I'm sure everybody on this call would know, suicide is a global problem. The WHO released its Mental Health Action Plan in 2013 and subsequently updated it. But in that action plan, there was a target for the reduction of suicide, which was a reduction by 1/3 by 2030 from 2013. So we took a bit of a look at global suicide data, and I'd like to thank Matt Spittle and Angela Clapperton for doing the work that sits behind this graph. So you can see that the age-adjusted global suicide rate actually has come down. So things have moved in the right direction, but we would argue that it's perhaps stalled a bit. And to really achieve that 1/3 reduction, we need to ramp things up. And the ramping things up, we would say, is by taking this fully fledged public health approach to suicide prevention. So what that means is paying much more attention than we have in the past to the social and commercial determinants of health, and in this case, social and commercial determinants of suicide. So when people talk about the social and commercial determinants of health, it's in recognition of the fact that individuals don't exist in a vacuum and their health is influenced by multiple contextual factors. The social determinants, those factors, are defined as the circumstances in which people grow, live, work and age, and the systems put in place to deal with illness, with these conditions in which people live and die are in turn shaped by political, social and economic forces. Sorry, I can't see my whole definition because my own picture is in the way of half of it. Key among the social determinants are commercial determinants. So commercial determinants would be regarded as one type of social determinants. And these are the systems, practices and pathways through which commercial actors drive health and equity. So throughout the series, we've woven in this emphasis on social and commercial determinants of suicide. And this is the model that we've operationalised that through. I'm just going to see if I can make my cursor do this. So the way the model works is the model highlights in this middle box individual risk factors, which have been talked about for millennia. So people talk about, in particular, clinical factors like mental illness being a risk factor for suicide. And it's true, it is a risk factor for suicide. There are also socio-demographic risk factors, for example, though, too, things like socioeconomic position, so people's level of education, employment, occupation and income, and also a whole range of contextual factors like stressful life events, job insecurity, homelessness, and so on. And in addition to that, there are some personality-based factors, genetic or familial factors, and neurobiological factors. But this emphasis on individual factors often comes at the expense of that context that I was talking about before, in which people live their lives. So we've emphasised this box, which is about the social determinants of suicide. So the social determinants are things like macroeconomic policies, public policies, social policies, legislative and regulatory frameworks, the healthcare system, the local environment, cultural and societal values, social cohesion and social capital, and importantly, those commercial determinants that I mentioned. So in the context of suicide, those commercial determinants are industries like the firearm industry, the pesticide industry, the alcohol industry, and the gambling industry, and others. So the model suggests that these individual risk factors don't operate in isolation. They're influenced strongly by these commercial determinants. And they're influenced in a way that often highlights inequity. So, for example, if you take austerity measures as an example that are introduced in times of economic crisis, those austerity measures differentially have an effect on suicide rates among people who are already struggling financially. So together, those social determinants and the individual risk factors can lead people to have suicidal thoughts and behaviours, and then for some lead to suicide. So we've taken that model and thought about how we might address suicide in the context of that model. And we've used terminology that's used in public health, elsewhere in public health. We've talked about universal interventions, selective interventions, and indicated interventions. So universal interventions target the whole population without trying to identify anyone who might be a particularly heightened risk. Selective interventions target those who are already at risk but are not necessarily yet displaying any signs of suicidal thoughts or behaviours, but they have individual level risk factors that might put them at risk in the future. And then indicated interventions are designed for people who are already experiencing suicidal thoughts and behaviours. So you can see that we've suggested that the universal interventions, selective interventions and indicated interventions move across the social determinants in individual risk factors. And in the series, we've particularly highlighted universal interventions, which are things like wellbeing budgets, income protection policies, social safety nets, debt relief policies. I won't go through the full list, but you get the gist. The other thing just to note in the response to the model is that we highlight postvention, which is activities or programs that occur once a suicide has happened, and they include things like bereavement services and suicide cluster response plans and a range of other responses. We've highlighted them here partly because they're part of that continuum, but also these arrows here show that postvention can actually also act as a selective or indicated intervention, because we know that bereavement by suicide can heighten subsequent risk of suicide. So the model works, you need to follow the arrows. So another way of thinking about this is this iceberg analogy. So at the tip of the iceberg, floating above the water, are individuals who are having suicidal thoughts or currently engaging in suicidal behaviours. And for those people, clearly a clinical approach is absolutely appropriate. If people are in a state of a suicidal crisis, you want them to be able to access the best possible clinical care. And in a public health framework, we equate a clinical care to an indicated intervention, one of several indicated interventions. So we're definitely not saying that clinical approaches aren't important. In fact, we're saying they're very important, but we're arguing that we need to broaden things out into this bigger public health approach, which allows us to initiate programs and activities and interventions that can be more upstream and prevent suicide at the source. So we can, and in particular, we can have some universal interventions that target the whole population, but in doing so, prevent suicide risk down the track. So in order for that to happen, because a lot of those social determinants are the responsibility of sectors that fall outside health, we've argued for a whole of government approach, a policy reset that thinks about things more in this whole of government way. So current national suicide prevention strategies, of which there are over 40, but over 40 countries have national suicide prevention strategies, tend to be driven by departments of health, and they tend to be signed off by health ministers. And they typically promote activities over which the health sector, and in particular the mental health sector, has control. So these are the kinds of clinical interventions that are extremely important for someone who is at the point of a suicidal crisis. And so that's great and all well and good, but we're arguing that's not enough. So we're arguing for this whole of government approach, which would have various features. So it would allow those other sectors, like, for example, the welfare sector, the housing sector, financial sectors, to think about the impact of their policies on suicide, but also the potential for their policies to prevent suicide, so that other sectors would also have a role in suicide prevention. We've called for a suicide prevention in all policies approach, which is about that thing about thinking of the impact on suicide and suicide prevention of particular policies in sectors outside health. We've also argued for sign-off by prime ministers or specially appointed ministers with cross-sectoral responsibility for suicide prevention, as opposed to health ministers. So we've argued that the enterprise of suicide prevention should be elevated to that next level so that it does become this proper cross-sectoral approach. And similarly, it's not just the ministers that will be reflected in, but we've argued for the involvement of policy makers from these other sectors as well. And we want to go even broader than that. We've argued that not only do you need a whole of government approach, but you need a whole of society commitment. So that means that relevant community, non-government and commercial sectors also need to get involved in the enterprise of suicide prevention. And importantly, the voices of people with lived experience of suicide should be given priority. They should have a seat at the policy making table, and have their voice should be heard as loudly and clearly as those other stakeholders who are sitting at that table. So that's all I have to say, and I think I'm making quite good time actually. So Keith, the floor is yours. I've got Keith's slides, so Keith's going to give me special instructions when he wants me to move on. I'll let you announce yourself, Keith.
Thanks very much, Jane. I'd like to now talk a bit more about some of the content of the series, focused on specific issues that might be addressed through public health approaches to suicide prevention. This next slide shows you a bit more detail about the content. As Jane said, there's one paper is focused on restricting access to means, another on economic aspects and government responses to economic downturn and other policies which might influence suicide. The fourth paper in the series is focused on transmission of suicide, influences of suicide reporting in the news and in entertainment media, social media influences, suicide clusters, education about mental health and suicide in schools to try and prevent development of suicidal ideas and their transmission, but also hopefully to prevent suicide in the longer term. And then lastly, suicide prevention campaigns in the media. And then the fifth paper focuses on some specific risk factors: alcohol use, gambling, domestic violence and abuse, and bereavement by suicide. We haven't covered everything. I mean, for example, we don't specifically address the topic of social isolation and loneliness, although we pick up on that a bit in the final paper. So if I have the next slide, if I can have the next slide, Jane, please.
Sorry, my slides aren't moving forward. Sorry, there you go.
Okay. Restricting access to means for suicide, use for suicide, is a topic of the second paper. And the reason for this is that this strategy really has the greatest evidence of effectiveness in terms of preventing suicides. And here we're referring not just to physical availability of methods of suicide, but also cognitive availability. In other words, psychological awareness of specific methods that might come from other people using them or reading about them in the media. And the rationale behind this approach is that having methods of suicide available may start people thinking about suicide, and of course may influence the translation of those thoughts into acts of suicide. Also, the relative lethality of specific methods will, of course, influence outcome, particularly whether death results from the use of a method. And we know from other sort of, if you like, indirect evidence that change in use of specific methods can influence population suicide rates. And we had a particular example of this in the United Kingdom back in the late 1960s, early 1970s, when we changed from domestic gas supplies from toxic coal gas to non-toxic North Sea gas over several years. And it's remarkable now to think that using domestic gas, particularly gas ovens, was the main method of suicide in the UK. And that change led to a huge reduction in suicide rates. Have the next slide, please. So I'd like to focus particularly on one approach, and that is restricting access to use of pesticides for suicidal poisoning. And the reason for this is that this method of suicide has contributed to a very large proportion of global suicides, particularly in lower middle income countries. And we now know that initiatives whereby highly hazardous pesticides, particularly toxic pesticides, have been banned has resulted in reductions in use of pesticides for suicides, and also has had an effect on population suicide rates. And one particular example is in Sri Lanka, where it was estimated that when there was reduced availability of highly toxic pesticides, which began in the late 1980s, but then was built on through into the 1990s and subsequently, between 1995 and I can't see the figure because it's blocked out by our pictures, but the mid-2000s, there were 93,000 fewer suicides following bans on toxic pesticides, and a very major reduction in the national suicide rate. If I can have the next, please. Another aspect of restricting access to suicide methods is concerns suicides that occur in public places, such as from bridges, cliffs, specific buildings, railways, roads, and so on. These constitute a fair proportion of suicides in most countries, and indeed in some up to as much as 30% of suicides. And we know that practical means of restricting use of specific sites known for suicides, particularly on bridges, sometimes combined with other initiatives such as ready access to emergency support, is generally effective, and importantly, without major displacement of suicides to similar sites elsewhere in the area. So restricting access to methods for suicide is a very important part of public health suicide prevention. But there are challenges, and one is from commercial interests, which have already been mentioned by Jane. And for example, getting rid of more toxic pesticides was not straightforward. There was considerable commercial objection to that, which had to be overcome and still applies in some places. There would be, for example, considerable commercial pressure against restricting access to firearms in the USA, where we know these are used in a very large number of suicides. There's also the risk of method substitution. In other words, if you reduce availability of one method, another method may become more common. And there was some indication of this in an area in India when toxic pesticides were removed, in that there was quite a substantial increase in deaths by hanging. And it's likely that one ought to implement other suicide prevention measures alongside specific measures to restrict toxic pesticides in order to counter method substitution. And all of this means that there needs to be ongoing vigilance in terms of methods of suicide, particularly to identify the emergence of new methods of suicide or increases in specific methods of suicide. And I think one needs to be aware that getting rid of a particular method or restricting it is not likely to be a forever solution, and one needs to keep an eye out for new methods or increase in methods that require other initiatives. Next slide, please. Another topic that is addressed, as we said, in one of the papers, the third paper in the series, is that of economic downturn and poverty, unemployment, and how governments respond to such circumstances. And we know that the suicide risk of individuals is increased if they are facing financial stress or poverty or become unemployed. We also know that recessions are associated with major increases in suicide, particularly in males. This happened during the Great Recession of 2008 to 10, the Asian financial crisis some 15, 20 years earlier, and of course the Great Depression before the Second World War. And we also know that where governments introduce austerity measures and other monetary measures, that is going to increase poverty, that this can influence suicides. Next slide. But there are some measures that we know may ameliorate the impact of economic downturn. And one is greater social welfare spending, where one tries to maintain funding, particularly for health, keeping access to health services and so on. This can help reduce suicides. We know that active labour market programs, where when there is a financial downturn, as many people are kept in employment as possible, this can also help restrict the impact on suicides. And there have been a number of studies that have shown that increasing the minimum wage in a population, even by a very small amount, can have a major impact on reducing or preventing an increase in suicides. And then there have been specific events that have shown how important this is, and particularly conditional cash transfers, where funding is given to people, the poorest in society, which is then combined with initiatives like increased attendance at healthcare, immunization, young people going to school, and so on. And a specific example of this was the Bolsa Family cash transfer program in Brazil. And over 10 years of that program, it was shown that those people who received the cash transfers were 56% less likely to die by suicide than non-beneficiaries of the program. Next slide, please. Another aspect, an important aspect of public health approaches, which we address in the series, is that of media influences and campaigns. And most of you will know about the Werther effect, whereby certain types of media reporting and portrayal of suicide can influence suicides. And we know from a recent review that reports of celebrity suicides can lead to quite a significant increase in suicide in the general population, and particularly if the specific method of suicide used by the individual is reported. We also know that fictional portrayals of suicide can sometimes lead to increases in population levels of suicide. And then there's the Papageno effect, which is whereby stories featuring narratives of coping, hope, and recovery following a suicidal crisis can lead to reductions in suicide and suicidal ideation. There's less evidence about this, but growing evidence. Next slide. One important thing that's happened over the last 20 or so years is the introduction of media guidelines for journalists and so on. And several countries have their own guidelines, but there are the World Health Organization, International Association for Suicide Prevention, collaborative guidance shown here. And you'll see bulleted some of the content of that guidance, which is about safer reporting, avoiding sensational reporting of suicides, not having suicides on the front page or in very prominent positions in newspapers, not reporting suicide methods, but providing education for the public about suicide, where to get help and support, and also encouraging stories of positive coping. And there is growing evidence that reporting of suicides has improved considerably since the introduction of these guidelines, and involvement of professionals in the development of guidelines seems to be particularly important. And there are also guidelines for the entertainment industry, where they are planning fictional portrayals of suicides. Next slide, please. And then there's the media influences and campaigns, and what these can do in terms of preventing suicides. And these would include programs such as the Know the Signs, an American program which is aimed at helping people become more aware of when people might be becoming suicidal and what they can do about it. An Australian program called Man Up, which is aimed at helping men who are in difficulty seek help. And there's evidence that both of these programs can lead to self-reported improvements. Whether they actually lead to reductions in suicides, we don't know. But there is also the fact that where messages about suicide and its prevention are delivered by key individuals or influencers, this can have very powerful effects. And a remarkable example of this is the song released by the hip-hop artist Logic, which had the title of the USA Lifeline number in it, 1-800-273-8255. The song is about becoming suicidal when faced with racial discrimination and bullying, but then turning to get help through a helpline. And this particular song received huge exposure, partly because it was involved in music awards, and it was shown that during the period of most extensive broadcasting, calls to Lifeline increased significantly by nearly 7%, and most remarkably and importantly, national suicides decreased by 5.5%. Next slide, please. We also focus in this series on suicide bereavement, as Jane said. Many people will experience bereavement by suicide. The lifetime risk of losing a relative to suicide is around 4%, and of losing friends to suicide is obviously higher, 14.5%. And we know that people who do lose individuals close to them by suicide have a considerably increased risk of suicide themselves. Next slide. So there have been a number of public health interventions to try and address this issue. Some of these have been preparatory measures aimed at preparing people for the possible experience of suicide. And such programs have been rolled out in universities and schools and other settings, particularly occupational settings. And we've been doing this recently in relation to mental health professionals who sadly we know will often experience, or many of them will experience loss of patients to suicide. For people that have been bereaved by suicide, there have been a number of booklets and websites developed containing information on likely bereavement experiences and support services. And the picture here of Help is at Hand is a particular example from the UK, a resource that's been widely available, freely available in both hard copies and online for many years, and is generally given out by police when they are called to suspected suicides, given out to families. And we know that it's appreciated by those who get it. And then where people have particular difficulties following bereavement suicide, there's been greater development of therapeutic programs offering support and care for those individuals. Next slide, please. Okay, so those are some of the specific topics. I've just chosen a few, but there are wider implications of a greater emphasis on public health approaches to suicide prevention. One important one is that it will help lead to greater recognition of the wide range of social determinants that can affect suicide. It's likely and hopefully to lead to more ambitious and expansive suicide prevention policies, and particularly policies that have more of an upstream focus that can help reduce the likelihood of people becoming suicidal. And as Jane has said, it's really important, if there's going to be full engagement in these approaches in terms of national strategies, that there be whole of government commitment from many sectors, not just health, but other sectors, and hopefully in a joined up way. Next slide, please. And as Jane has said, also it's very important, and we emphasize this in the series, that there be greater involvement of people with lived experience of suicide and suicidal behavior in the development of policies. They can help shape public health interventions. We've had a very good example of this in the UK recently in relation to social media, where a father of a 14-year-old girl who died by suicide, having been accessing some pretty influential things on the internet, died by suicide. And they can also help in highlighting points for evaluation, not just outcome in terms of suicidal behavior, but other impacts that may be particularly important for individuals. But their involvement does require full and it must be a meaningful involvement, not just in the design of policies, but in their evaluation and indeed in research. Next slide, please. Evaluating public health interventions, as we highlight in the series, can be challenging. One often has to use ecological designs such as before and after evaluations, or evaluations of one area where there's been an intervention compared with another area, or interrupted time series evaluations where you look at the change in impact of a specific intervention over time, perhaps against what would have been the likely projected incidence of a particular method of suicide, say if the intervention had not occurred. But such evaluations require large data sets and also lengthy follow-up periods. And then there's the issue of data availability, of good quality data. The advent of real-time suicide monitoring in many countries, or near real-time monitoring, has been important in this regard and really provides us with a greater opportunity for evaluation. Next slide, please. Okay, well, I'm now going to hand over to Rakhi Dandona, who's going to talk about applying public health interventions in low and middle income countries. Thank you.
Thank you, Keith. I just share my thank you, Keith, for that presentation. Hello, everyone. I would talk about specifically what the series means for low and middle income countries. Why are we talking about low and middle income countries specifically in this series and in this webinar? All of us know more than 700,000 people die by suicide globally each year. This global map here shows the suicide death rate by country. As you can see, most of the map is either this orange or this yellow. The average global suicide death rate is about 9 per 100,000 deaths every year. If I just take a minute and explain to you what this actually means, we have three presenters today. I'm from India, Jane from Australia, and Keith from UK. Australia suicide death rate is about 13 per 100,000, which translates to about over 3,000 deaths every year by suicide. UK is about 8.5, which translates into about 6,000 deaths a year. India is actually similar to Australia, which is 13 per 100,000 suicide deaths a year, but it translates into 180,000 deaths a year. So what this means is that in terms of numbers, 7 in 10 deaths by suicide occur in low and middle income countries, which is where most of the world's population lives. So if I change this map by numbers, it would look something like this. This is where most of the burden of suicide death remains. I would try not to repeat what Jane and Keith have already talked about. All of what they've said is very relevant to low and middle income countries setting. I am going to frame it within the social development goals and how this is, and some of the challenges and how it's relevant within the SDGs for these countries. The Global Target 3.2 of SDG does talk about reducing the suicide death rate by 1/3. However, if we have to monitor these SDG goals, including suicide mortality, it depends on availability of continuous data, detailed data on mortality or deaths by age, sex, and why people die, which is typically available from a civil registration or vital registration systems around the world. So you need to know how many people die and why they die to understand if we are reaching towards the SDG goals. This is a global map showing a recent research undertaken to assess what is the quality of civil registration system in terms of how good these systems are for us to provide the mortality estimates that are needed for us to monitor SDGs. So the lighter the blue, the worse it is. So the moderate, weak, and low are, so if you look at all of this map, most of the world where the population lives, half of the population lives, actually has either low or weak vital registration system. So which means that we actually have poor data on mortality to have a good sense of numbers and cause of death. Specifically coming to suicide death rates in 96 countries, which account for about 60% of the global suicide deaths, are actually based on modeling methods. So big challenge for these countries is to get the numbers right, to get the magnitude right. And that can happen with a public health approach. And I'll detail a bit of that here now. For many LMICs, the data on suicides actually sits out of the health system. What this actually means is that many of you who are on the call today from LMICs can relate to this. The hospitals kind of deal with self-harm attempts, but if the person is already dead before reaching the hospital, and many of us can relate to this term, dead on arrival or brought dead, as is written in many LMICs, that death kind of stays outside of the health system, or the understanding of why this death happened kind of stays outside the health system. Now, to add to this, in many of the low and middle income countries, irrespective of the changes in laws, practically suicide is still considered as crime, which means that it gets recorded within the police system. So the deaths are recorded here, and that's true for many injuries and not only suicides. So it gets recorded within the police system. The police is recording this as administrative data. Police are not collecting these data to provide evidence for suicide death rate in a population. So we need to understand where the data in low and middle income settings are coming from, and the fact that the health system needs to broaden its collaboration to capture suicide deaths, the magnitude of suicide deaths, for it to be actually seen as a true public health problem, which is a big change that's needed as part of the public health approach that we have argued in this series. So broadly speaking, we are talking about suicide mortality data here, but it's within the broader context that we actually have poor mortality data for a variety of things in these countries. Suicide deaths are part of it, but because of underreporting stigma issues, we could expect a bit of larger challenges that we need to address to get suicide mortality right. But all of this is what we talk about when we say that we need to improve the data on suicide for planning proper action to reduce global suicide mortality accurately by the whole government approach. So, for example, here, the health system needs to work at least with the legal system, for example, to get the number and the burden of suicide deaths appropriate in these countries. The other challenge is that suicide prevention so far has been seen within the mental health space. And mental health is important. But in this series, what we're arguing, as Jane said, is it's important, but there are other things that are equally important in addition to mental health. And this is Keith have already presented a fair bit of risk factors that are primary stressors beyond or other than mental health that are responsible. Poverty, debt, addiction, domestic abuse, discrimination, social isolation, ill health, family issues. All of these in various bits are relevant to many of the low and middle income settings. So what we are saying is we continue to focus on mental health, but we also need to focus on these primary stressors that are risk factors for suicide deaths in many countries, actually globally. So what this means in practical terms is, many of you may be familiar with the statement by Desmond Tutu, that we need to stop just pulling people out of the water, out of the river, which basically means that just focusing on mental health for those who have mental health conditions or are suicidal is not enough. That's important, it's not enough. We really have to go to this whole government approach, the public health approach, to figure out how do we get less people to fall in the first place. And that's how the public health approach works, including the mental health approach. It's not without it, it includes it. This is what Jane presented in her iceberg approach, that we need to look at all of it and just not part of it. What would it mean practically in terms of social determinants of health and SDGs? As I said, there's already a suicide rate target within SDGs, so it allows us that conversation space for suicide prevention to talk about within SDGs. And the social and economic risk factors that we have heard, and many more are in the series, clearly relate to many of the SDGs that we already have. So all we are saying is, in practical terms, is that we need to consider and talk about suicide prevention across the SDGs as relevant, because that's when, once we have those conversations, once we consider suicide within this space, it will have the potential to directly impact the risk factors, the primary stressors that we've talked about for suicide prevention or suicide reduction to be actually at the large scale that all of us hope to achieve for the SDG goals that we have. Thank you.
Thank you very much to all the presenters. Those were very, very interesting presentations, and they've prompted a whole load of questions, which I've been picking out from the Q&A and from the chat. But if people could use the Q&A, that would be great, please. So I'm going to start off with a question here, which was about what our opinion on euthanasia is from a public health perspective. So I'm going to ask Jane to answer that, please.
Well, I would say that the series is absolutely about suicide and not about euthanasia. So we've thought long and hard about what a public health approach to suicide might look like, and some of the, in particular, as I said, some of the universal interventions that might be delivered in this whole of government way. I guess I would feel a bit uncomfortable commenting on how you might then apply that approach to an area that we haven't really considered in the series, except to say that I think in lots of ways the public health approach is appropriate for multiple issues in health and in health generally.
Could I come in here, Alexandra? I do think this, is a really important question, and poses, it does highlight what may be and is being and will be a major challenge for suicide prevention generally. And if we think about it in terms of assisted dying, then assisted dying policies, particularly where these include assisted dying for mental health problems, which of course applies in some countries now and is likely to become more common, I feel it raises very important questions about our approaches to suicide prevention. And people could rightly say, well, you're trying to prevent suicide, but at the same time, you're allowing, people who are feeling suicidal, perhaps because of mental health problems, to be assisted to die. And so I think that it's a real challenge to suicide prevention policy, but it's one that must be discussed very, very openly in societies. I don't have any specific answers to this, but I do think it is a really important one that we need to keep in mind and openly debate. I won't say any more than that at this point, but I think thank you for whoever raised that point. I think it's a really important question.
We also have a question about the influence of drug or alcohol use as risk factors for suicide. And I wanted to ask Keith if he could comment on what the public health approaches to this would be.
Yeah, I think the main emphasis should be on alcohol. I mean, obviously, there are associations between suicide and drug misuse, but in terms of numerically, the influence of alcohol misuse is far, far greater. And we do try to address this in the series. I think it's fair to say that, well, first of all, that the challenge I mentioned in terms of commercial interests rears its head very much when you start talking about alcohol, because obviously one approach to trying to reduce the influence of alcohol on suicides will be a reduced availability or increased pricing minimum pricing for for alcohol. I do think it's something that public health policy needs to embrace. And there's a particularly good example of this in Scotland, where minimum pricing of alcohol was introduced a few years ago. And there's been a publication this year showing that this appears to have resulted in reduced deaths from alcohol-related causes, not suicides. Suicides weren't reported in that paper, but it does raise the question of whether policies like minimum pricing might be effective in reducing suicides. And it's got to be something that is embraced in public health suicide prevention policy.
Thank you. I've got a question here that perhaps Jane could take, which is whether the reviews touch on Indigenous health and well-being and any public health approaches that take Indigenous knowledge into account.
I think it's touched on. It's not the primary focus, but absolutely, I think that we certainly call out cultural issues and stigma and discrimination and factors that might disproportionately affect Indigenous people, and think about those in a whole of government way as well. The kinds of things that we can do to change things, I guess.
I've got a question for Rakhi, please. And one of the attendees wondered if you could put up your slide again, which showed the distribution of suicides by region, because I think that was really arresting. Is that possible to bring that up again, Rakhi? And then I can ask a question that relates to your presentation. And one was, what should researchers from low and middle income countries do as a step to bringing down suicide rates? And I'm just going to pair that with another question, actually. The question was really hearing your perspective on how inequalities in social, economic, and related conditions hinder the development of effective strategies in low-income settings, and what steps can be done to overtake these challenges.
This the slide.
I think that, yeah, I think that's the slide. Do you want me to repeat the question, Rakhi?
Yes, please.
Yeah.
Yes, please.
So it was two questions, really. One, a very broad one, which was how can researchers from low and middle income countries bring down suicide rates, but more specifically, how just hearing your thoughts on how inequalities in social, economic, or related conditions hinder the development of effective strategies in those settings.
Perfect, thank you. I think the biggest challenge in low and middle income settings is the availability of data that allows us to understand the burden and then understand the burden by, let's say, age group, by sex, by occupation, in terms of numbers, in terms of risk factors or reasons and methods of suicide to actually take action. So my first major priority would be within the settings for us to start collecting the data in a manner that allows us to understand where the problem is, why the problem is, so that we can actually have implications, affect the problem by appropriate interventions. That's a big challenge. And that is also true for addressing inequalities. I think I heard in the question social and economic inequality, and to that I would like to add gender inequality as well. Again, it's related to the availability of data. Majority of the data is available in terms of broad numbers. The rates are available in terms of broad numbers. But again, the inequality comes when you have data enough to look at how is it by age group, how is it in lower socioeconomic status people versus others, how is it between men and women. I've worked with a fair bit of data that are available and published as part of Global Burden of Disease study. And unfortunately, much of the data that's reported is not disaggregated enough for us to make sense of the levels of inequality in terms of burden or reasons or risk factors. So my answer to both of these would be, let's start collecting the data and report the data in a manner that allows us to answer both of these questions. Thanks.
Thank you very much. So the next question is, I've got a couple of questions for Jane actually regarding stigma. So more generally, how can public health initiatives reduce the stigma of suicide? And also, what is the impact of stigma, religion and law around suicide on global suicide deaths?
So I think stigma is really important. I think that the stigma surrounding suicide and some of the other things surrounding suicide too. So like you mentioned, law. So the criminalisation of suicide in certain countries has a really big impact on people's likelihood of seeking help. So, so that societal level approach to reducing the stigma around suicide and educating people about suicide is critical. So Keith talked, for example, about media campaigns and about, in particular, and for example, the Logic example, which is not really a campaign. It was a very fortuitous, serendipitous kind of suicide prevention activity, really, was partly about reducing the stigma around help seeking, normalising help seeking as a response. So I think there's lots of things we can do, but it's not simple, because stigma relates to the societal view that we collectively hold about suicide in different countries and in different cultures. So it's shifting that sometimes.
So I've got a question now for Keith, please. And this is relating to the point you made about real-time monitoring of suspected suicides. So one of the attendees has said in Scotland, they've been testing a workshop in local authority areas. And this uses an unfolding scenario to stress test local system-wide postvention response plans. And so this is a kind of emergency response planning approach. And it covers information sharing, locations of concern, support for people who have been affected, how one might respond to a potential cluster, the issue of memorialization and communications. Can you comment on similar in England or any other countries?
Yes, well, the first point was about real-time surveillance. I think the point began talking about real-time surveillance. And of course, in the UK, well, England, Scotland, and Wales, we now have real-time surveillance maintained by the police service, and it covers pretty well all areas now, and it's sufficiently good that we have 2 to 3 monthly releases, updates on suicide rates nationally from the real-time system. Of course, we have to rely on our official suicide statistics from the Office of National Statistics to provide the ultimate figures on suicides. But it looks as though the real-time approach, which is run through the police, is obtaining data that are broadly equivalent to the official suicide figures, which appear sometime, many months later. So that's certainly been working well. And that, I think, is, and in a way, it links to what Rakhi was talking about, because I do think getting good data is absolutely crucial to providing an underpinning for an effective public health approach. And I was thinking, sorry, I'm diversifying here a bit, but to what Rakhi was saying about the need for good data in the middle-income countries. And I wondered, when suicide gets decriminalized, for example, as happened in India what, 3 or 4 years ago now, I forget the actual date, how long it actually takes for attitudes within the services to change, such as the police services, such that they can start to collect more accurate data without, you know, this being influenced by maybe prejudice or attitudes or whatever. And this is getting away from, maybe I can pass that one to Rakhi as a question, if I may. But coming back to the specific question, I think the sort of developments in Scotland, which does seem to have a developing whole of government approach, unlike most national suicide prevention policies, is admirable. I think, you know, well, from what I know about suicide prevention policies in other higher income countries, many of them are trying to incorporate the elements that you, the person who asked the question, described as happening in Scotland. I think things are moving forward in many countries in terms of suicide prevention efforts. And I think back, you know, over my career, which is, you know, now quite a long one, to what, you know, the situation was when I first came into this field, when there's very little discussion of suicide prevention at all, except within psychiatric services, where people are obviously trying to prevent patients dying by suicide. But in terms of attention to public health measures, there was virtually nothing. And we've come a long way. I think we mustn't forget that. We shouldn't become complacent. And the sort of developments that the questioner raised, mentioned as happening in Scotland, I think are beginning to happen in many places. And that's probably partly why the global suicide rate at least has shown some decline, if not enough of a decline in terms of the WHO targets.
Rakhi, did you want to respond to that?
Changing mindset of the police, yes. I think the biggest challenge with that, Keith, is that we really haven't worked with the police yet. You know, we've kind of decriminalized it, made a big noise about it within the mental health space, the health space, but we really haven't gone down to the details of what it actually means on ground, which means that involving police in this understanding and how data are collected. And also we haven't really talked about in layperson terms what it actually means, because community also needs to understand that it's no longer a crime and it can be reported. So we really haven't worked on those two aspects for the most part, which is typical of many other policies. So this is not unique to suicide again, you know. So we have policies and programs in place, but we do not do the last mile of how do we implement it in practice. But there is a fair bit of conversation now around this, because unless you involve police department, the legal department, things will not change. So there is some movement, but it will take a long time.
Thank you. Jane, I've got a couple of questions here about public health approaches to preventing suicide, specifically in adolescents, and whether we had any specific insights on that. And there were 2 points that were raised. One was from somebody who conducts a lot of seminars in schools with teenagers, and they wondered whether adolescents' friends can influence how they feel about suicide. And a second point was about the issue that many adolescents who feel suicidal or make a suicide attempt are offered inpatient treatment, but this can be really stigmatizing and isolating and remove them from their natural support network, but often without any clear benefits. So it was thinking about how we might rethink this approach to youth suicide prevention in a situation where they were actively suicidal. So a bit of a broad range of questions there.
Yes, and I'm sure I'll forget the second one by the time I finished answering the first one, so you might have to repeat it. But just to say, so we there's definitely a focus on suicide prevention among young people in the series. So, for example, as I think Keith mentioned, we have a section on schools as a setting for suicide prevention. We've got a section on social media in several of the papers. Just for as by way of examples, we talk about in both of those. We talk about the fact that adolescence is a particular period where risk of suicide might be heightened, but also that there are opportunities for prevention, both, for example, through social media and through in the school setting. We all, in amongst that, we talk about the potential for young people to seek support from their peers online or at school, and talk about some of the programs that have been developed to equip young people to help their mates. We also do mention, though, the fact that it's probably not fair and reasonable to expect young people to do everything for their peers, so that there's also a need for, in schools, for example, equipping school staff to be able to know what to do if they're concerned about someone in the school setting. And sorry, I knew I would. I forgot what the second part of the question was. Most of that was about the peers, I think.
Yes, and I think that was more of the public health aspect of this question. The other side was more about the role of inpatient admission and how it can be very, very stigmatizing. And I assume, you know, the focus of this series is much more about upstream approaches in tandem with the clinical approaches.
Yeah, it is. We do know that from various studies that some young people certainly have bad experiences when they encounter the mental health system, but also some have really good experiences. I guess the public health approach would be trying to make sure that young people are pointed in the direction, if they do reach that point of crisis and needing support, that they're pointed in the direction of services that are likely to be helpful.
That's great, thank you. Well, the next question also relates to young people, but in relation to social media influences. And this one I'm going to ask Keith to respond to, because one of the attendees had pointed out that when a teenage girl in the UK, Molly Russell, died by suicide at the age of 14, which was received a lot of media attention and was a landmark case because a member of an executive at Meta appeared in person at the inquest. But the point was that it wasn't just that she was accessing harmful material on the internet, it was also that she was being sent harmful material by direct message. And so I wondered if Keith could comment on public health approaches to addressing that aspect of social media exposure.
Yes, well, from that particular very sad case and several others, we know that exposure to online material relating to suicide and self-harm can be extremely important. We know that there are agencies out there which actually promote suicide. We also know that conversations between individuals and within groups about suicidal behavior can be influential, and that images in particular of suicidal behavior that appear online can have major impacts on young people. So it's been a big focus, and the Molly Russell case really particularly highlighted this in the UK, on what can be done. And one thing, of course, that's happening here is that we've had the government's online safety bill introduced, which is aimed at trying to, particularly for under 16-year-olds, to restrict access to any sort of influences of that kind, and hopefully to restrict younger people 16 and over having access to certain particularly malign influences that may come about online. We don't know how effective that's going to be. It's a bill that's only been introduced recently, and the aim is to try and stop platforms that host such material from doing so. And obviously there's going to be challenges coming along during the next year or two where this will be tested, and we'll know whether that is effective. It becomes much more challenging when you start to think about communication between individuals, because and it's been argued that it would be very restrictive to try and stop people communicating about self-harm or suicidal behavior between individuals or within small groups. Of course, a lot of people get support through being part of groups, online groups. And of course, also, one hears stories of recovery and improvement through help that people are getting online. So it's a very complex area. But I do think the first thing is about stopping platforms hosting the really, really badly influential material that leads to deaths like that of Molly Russell. And we'll see how that works, whether that the online safety bill has enough teeth to have an impact, and whether it might be something that other countries might then roll out if they're not already doing so.
Thank you very much. Now I've got a question for Rakhi about estimating the number of suicides in low and middle income settings. And the question was whether you could speak about the contribution of the insurance industry to underreporting, given that in many such countries, death payments might be withheld if the death is attributed to suicide. And maybe also if you could address a question, Rakhi, about whether there are countries that might be emulated in terms of gathering data within low and middle income regions.
Insurance may have a role to play, but I haven't looked at the data myself, or am aware of data specifically for how it influences suicide, reporting of suicide deaths. But yes, broadly speaking, we do know that within developing countries, it makes a difference as to what's reported as cause of death within the insurance system. Having said that, we also know that many people who die by suicide are also unlikely to be insured. So I think we just have to find that, find the right, understand the data better, because many of them, for example, are daily wage earners, unemployed men, housewives, and insurance is not that common in these settings and for these people. So it may have some influence, but I am not able to speak to, the extent of that influence at this point. What was the other question, Alexandra?
There was an interesting question about whether there were countries within low and middle income regions where one might want to emulate their systems of data collection.
Interesting question. I'm not aware of data within the police system. But Bangladesh, for example, is one of the countries within the low and middle income countries that actually undertakes injury survey by support of government. Ministry of Health funded, which is fairly unique because they then collect the data on injury mortality across a variety of unintentional and intentional injuries, which is very unique, which means that, and they've done it many times. So which means that the government is actually able to have robust data to track the suicide, the trends in suicide death rate over time. But within police system, I'm not aware of any country that does it well.
Okay, thank you so much. I've got a question for Jane, which is a challenging one because it's been pointed out that some public awareness raising campaigns have been shown to have negative effects on men, in that it seems to be associated with lesser help seeking, more negative attitudes. And the same applies to people with mental illness, particularly people with depression. So the question is, what do we do about that, and how do we prevent negative influences of these awareness raising campaigns? And there's a second part of the question. I'll say it now, Jen, but I can remind you of it
You
later.
don't have to repeat.
Which is that knowledge is a kind of necessary prerequisite to behavior change, if we think about psychological models of behavior change, but it's not sufficient. So how do we tackle, when we're trying to encourage behavior change, more subtle factors influencing attitudes and intentions regarding suicide as an option? Because the suggestion is that public awareness campaigns just won't do this. And the suggestion is that this is where the holistic approach you talked about might kick in. But, you know, this is very difficult to achieve. So your thoughts on that, please.
So I would say that the thing with public awareness campaigns is that there's a building body of evidence on them, and some of them have been shown to be really quite effective, and others have not been shown to be so effective. Some of it is to do with the dose, you know, the amount of campaign material that people see, you know, whether you would expect a 30-second community service announcement to have a really big impact. But I also think that we, the collective we, haven't yet done enough to work out what messages work for whom. So there are campaigns that are probably quite useful for one group, but might not be so useful for another group. So I think we need to be really clear who the campaigns are targeting and what messages are likely to resonate with them. So I think that's the second question about changing attitudes. I actually think that some campaigns have been shown to change attitudes. I think that it's true that it's probably easier to change knowledge than attitudes, but attitudes can be shifted, and so can intentions. I think the thing that is difficult to demonstrate is that, and I think Keith mentioned this, that the campaigns have an impact on actual behaviour, and that it's tricky because, you know, often the kinds of campaigns that get released in suicide prevention are either designed to equip the general community to reach out to someone who they're concerned about, or encourage people who are at risk themselves to seek help. And sometimes there are campaigns that sort of do both. But either way, it's often the case that the people who see the campaign won't need to enact the behaviour immediately, and not all of them will. So it's hard to track the behaviour change that might be associated with a campaign, but it's obviously possible. You know, the logic example that Keith gave is a fantastic example where not only was behaviour change, people rang the lifeline number, but also the suicide rate came down in the peak period. So I think that there are things we can learn from how campaigns are delivered and how those sort of incidental campaigns are delivered. Why is it that influencers are so influential, and how can we capitalise on that? But also I think there are things we can probably learn from the advertising industry. The advertising industry releases campaigns all the time that change people's behaviours so that they buy sneakers or whatever. So I think and maybe some of our campaigns are a bit too earnest and worthy and less likely to have an influence. So there's a whole lot of things in there, but I think thinking through the kind of messaging in campaigns and the look and feel of campaigns is important, and who they're targeting.
Thank you. And I wondered if Rakhi might comment on that from her perspective.
I just wanted to add, I agree with everything that Jane said. I just wanted to say that we're talking about a public health approach, which also means that, you know, we could learn from other campaigns. HIV/AIDS is a fantastic example. You know, this is a disease that was stigmatized, And Thailand did a fantastic job of, taking care of that stigma so that people can actually talk about the disease and take action. So perhaps we also need to learn from other stigmatized conditions. TB is another example as to how those campaigns or those disease conditions have actually moved forward. And if we are saying that suicide is a public health issue, so I think it might be good for us to kind of learn from other public health conditions that have been stigmatized and have managed to create that momentum within the community in terms of awareness and action.
Great, thank you. I've got a question for Keith about access to means. And the question is there any research around how to address access to means, whether means are a vital part of the job role? And this is with, specific reference to vets, farmers, and people in the construction industry, perhaps.
Yeah, thanks. That's quite a challenging question because obviously, just thinking about the medical profession, we know that although certainly in our country, and I think some other countries, suicide rates in medical professionals have declined. We also know that people working within health, be they doctors, nurses, or others, often do use methods which are more readily available to them because of working in those settings, and particularly medication, or, for specific example, anesthetists using anesthetic agents and so on. I think it's a really difficult one, but I think the first thing is to make sure that people who are in charge of those settings are aware of the potential dangers. That may sound obvious, but I don't think that's always the case. And that try and ensure that the particular dangerous methods aren't too available, and B, what to do if someone is clearly in difficulty in developing mental health problems and potentially becoming suicidal, and whether there might be means of restricting their access to those particular methods during times of major difficulty. The construction industry is a really challenging one, obviously. People working in that industry have obviously access to means, particularly for jumping and methods like that. But I think and I might be corrected here by Jane, I'm not sure whether we have that much knowledge about the methods being used by people working in the construction industry. And Alexandra, I know we've discussed this in relation to the UK, that we don't have those data at the moment about what methods they are using, and whether they are using methods which are particularly available to them because of their work roles. So I think it's another situation where really good quality data is required to decide what might be most appropriate policies. But having said all that, restriction of access to means is an important public health policy. It's not quite as upstream, if you like, as some of the other policies we've been talking about. And I think that emphasizes again, the need for thinking upstream to try and prevent people getting to the stage where they're becoming suicidal, and where access to means then becomes particularly relevant.
Thank you very much. Now we've come to the end of our 90-minute webinar, and we do have a huge number of questions left, unfortunately. We've tried to address as many of them as we can, but thank you so much for your questions. The EASP team are going to be sending out a recording of this webinar later on this week, and the slides will be visible within that recording, but not sent as separate files. So I wanted to end by thanking all the speakers today. Thank you so much for your presentations, and to all the authors of the articles, the 6 articles in the series, and to Lancet Public Health for commissioning this series, and to EASP for their support of this webinar. Thank you very much indeed.
And thank you, Alexandra. Great chairing.
Thank you.
Thank you.